Hi, my name is Elise. I am the nurse caring for the patient today. The patient is a 27-day-old premature male presenting with episodes of apnea, bradycardia, and desaturation, being treated for this with a high-flow nasal cannula at 4 liters per minute. Patient has also been struggling with emesis, who has an OG tube where we do feedings, and he's getting mother's milk flowing at 36 milliliters every over 105 minutes. Patient's past medical history. So the mother was a 42-year-old female in which she had an emergency cesarean. Patient mother had an abruption and the patient was in breech position. Patient was born premature at 29 weeks and 4 days. Respiratory failure and apnea upon birth, as well as experienced a intraventricular hemorrhage grade 2. Some patient safety that we have in place is the patient is in a plastic bassinet, so there are walls on the side of the bassinet, keep the patient safe. There is also an O2 mask on the wall that is already pre-set up and ready to go in an event for potential resuscitation. There you can also see the patient ID band on the patient's ankle. So some developmental things about this patient. Patient is in the trust versus mistrust stage, and so some adaptations for care to accommodate for this stage have been to hold the baby, hold the patient when possible, encourage skin to skin when the mother comes in to spend time with the baby, wrapping the baby in a nice warm cozy blanket, also to warm the baby's feet and heels, and then not do a heel prick, just so that they don't associate the warming of their feet with the pain of a heel prick. To go on, to continue on, the pathophysiology for the patient's condition. The patient is premature, so the lungs are the last major organ to fully develop in fetal gestation or fetal growth. Upon birth, he had immature lung development, and with that, didn't have enough surfactant in his lungs to inflate that alveoli. Without the inflation of the alveoli, patient is struggling with the gas exchange that is needed to ensure that baby is getting enough oxygen, and that struggle with oxygen can cause some problems and lead to respiratory distress. So some abnormal vital signs for this patient would be an oxygen saturation that's below 92%, and a heart rate that is below 80 beats per minute. This is significant because in the event that occurs where the oxygen is low and the heart rate is low, it is indicative of a ABD episode, the apnea, bradycardia, and desaturation, in which if the episode isn't self-corrected by the infant himself, would then need nursing intervention quite immediately to make sure that we are restoring the breathing of the infant. So some complications to watch out for: possible aspiration. That'll be signs of grunting, gasping, change in lung sounds, decreased oxygen sats, and some nursing interventions, if that does occur, would be suction. Some blow-by oxygen help with the breathing, as well as contacting the provider in the event of aspiration. Another complication would be bronchopulmonary dysplasia. Some signs of this would be failure to wean oxygen, increased work of breathing, poor expansion on a chest x-ray, with the chest x-ray, obviously you'd need one ordered, but if that is noticed, you want to notify the provider. But if you do see any of the other symptoms, you do want to contact the provider. You want to be doing, or frequent assessment of lung sounds, as well as contact the respiratory therapist. And lastly, a third complication would be infection. So that would then present as like a fever in the infant, or just temperature instability. Baby isn't able to maintain temperature and it just kind of fluctuates low and high. It could be mottling of their skin, decreased appetite or irritability. In the event of this, you do want to contact the provider. You want to be monitoring temperature. If you notice mottling, you want to ensure that the baby is warm, and then also implement some infection control precautions. So now with advocacy here at the hospital, there is a policy that during RSV season, only 2 adults are allowed per patient at the NICU, and no children allowed at all whatsoever. This is just to ensure patient safety and health. And some good ways to go about approaching advocacy for this policy is just educating patients, letting the family of the patient know that it's in the patient's best interest for their health to limit contact with outside germs, since the baby is struggling to continue to develop since they're at the NICU. They also haven't gotten any vaccines yet. So we want to make sure that we're not introducing anything that their little bodies won't be able to handle. And lastly, just with my reflection of care, so during today's visit, the mother was able to pop on by, and she pumped for some extra breast milk for a baby, as well. She wanted to do some skin-to-skin time with the baby. So we were able to adjust our nursing cares for the patient to ensure that mom was able to spend as much time, or just make use of the time that she was there with the baby, so that she could do that skin to skin and have that quality time and reinforce that trust with Erickson's developmental stage that we see. So it was just a good reminder to know as a nurse that the patient really is someone else's kid, and just as mom caters to baby, we as nurses cater to mom and baby. We want to make sure that we're facilitating that kind of relationship that will continue on once they go home, since nurses won't be there when they go home, the baby. And then lastly, implementing the healer's art in my care for the patient today. I just tried to talk to the baby. I mean, I know they don't understand what I'm saying, since they are just an infant, but talking with them, being loving, just spending that quality time with them, and kind of establishing that trust, reinforcing that trust and that love, just was just a nice moment to be able to care for this infant that I'm obviously not the mother of, but their mother's not there. I can't be there all day to care for them as they normally would when they're back at home. So to fill that role, to kind of feel that Christ-like maternal love, was just a really unique and amazing experience in today's care.